Good evening, everyone. Now we have come to the most awaited part of the evening of the CME, that is the live neurological case discussion. The case discussion will be examined by two highly eminent personalities, Dr. Anand Sharma and Dr. Anand Kumar. Speaking of Dr. Anand Sharma, he is a former professor and HOD of Department of General Medicine, Government Medical College, Kottayam. He was also former professor and HOD of Department of General Medicine, AIMS, Kochi. He was a former professor and HOD of Department of General Medicine, Pushpagiri Medical College, Tiruvalla. He is currently working as Emeritus Professor of Pushpagiri Medical College, Tiruvalla. He has also received the Best Teacher KGMCT 2002 Lifetime Achievement Award from Kerala Chapter. He was the Dean Faculty of Medicine at MG University. He was a chairperson of postgraduate studies in Faculty of Medicine at MG University, and he has received Eminent Teacher Award by South Zone Association of Physicians of India. I humbly welcome you, sir, to this case discussion.
Thank you.
And speaking of Dr. Anand Kumar, sir, he completed his MD from Government Medical College, Trivandrum, and his DM from Sri Chitta Tirunal Institute of Medical Sciences and Technology, Trivandrum. He's currently working as a Vice Principal of AMRITA School of Medicine, Cochin, and Professor and HOD of Department of Neurology, AIMS, Kochi. I humbly welcome you too, sir.
Thank you.
The examinee will be Dr. Bhagya. She's a final year JR, Department of General Medicine, AIMS, Kochi. I'll be handing over to Dr. Bhagya.
Hello. Hello.
Good evening, sir.
Good evening. Good evening. Hello. Am I audible?
Yes, sir. Yes, sir.
Yeah. First, let me thank MGK Pillai and the team for giving me this wonderful opportunity. I am really honored because I am chairing with the doyen of neurology. That person is not only doyen of neurology, but has got multitasking capacities. He writes poems, writes music, and also sings music. In YouTube, we can see. Such a personalities, I am sharing the platform. Thank you so much, Pillai, for this wonderful opportunity. Now, when you are presenting, don't get tense. There will not be any sort of teasing and all that, only teaching. Not in the like the local class, in the morning and all that. Not like that. Therefore, be bold and tell what you want to tell. Okay.
Sure, sir.
Right, sir. And
Good evening, sir. May I just say a few words? I will also like to thank Dr. M.G.K. Pillai, and the feelings are mutual. It's a great honor and privilege to share the podium with Sharma sir, who is my guru, and I touch his feet whenever I get a chance. He's also a multi-talented personality. We are writing a book together, and he has kindly given me the privilege of contributing. And he is also a great musician, very talented connoisseur of music, especially classical music. And he's a avid reader, and from 1977, he has got all the CPC NEJM copies, and he is very passionate about teaching and learning. So I'm very glad to be here. Thank you. And the format of the discussion, as I understand, is I will be discussing the history, and Sharma sir will be discussing the science or examination. And Sharma sir will be concluding. I think that is how it will go.
You can start.
Yes, sir.
Go ahead. All the best for you.
Thank you. Thank you so much, sir. Good evening to everyone. I'll be discussing a neurology case today. I'll be discussing about a 39-year-old female. She studied till 12th standard, who is a homemaker now. She was hailing from Thrissur. She's a right-handed individual and whose mother tongue is Malayalam, and history was obtained from the patient herself and is reliable. She came with chief complaints of history of imbalance in walking for 9 years, speech abnormalities for 6 years, and involuntary movements in the hand for 5 years. She was consulting regarding this symptom in an outside hospital, and she was being evaluated there, and hence referred here for second opinion. History of presenting illness. history of imbalance while walking for 9 years. The onset was around 30 years of her age, and initially she noticed it post delivery while she was walking to the bathroom, and she was able to walk by herself, and she took treatment for the same, and but she was able to manage her day-to-day daily activities, and but she had difficulty in navigating through a narrow passage. And over next 2 years she started developing a swaying while walking, which was bilateral, and her relatives started asking if she was drunk, and her disability progressed slowly, such that over next 5 years she started requiring and over next 5 years she needed to hold to a furniture to walk. Since last 3 years she needed a walker or a chair to move around inside the house itself, and since past 1.5 years she was not able to stand by herself and she needed a two people support. She also had difficulty in getting up from the chair or bed, and she also needed to hold some object to get up from the bed. And she had difficulty from getting up in the commode, but she can roll over a bed, and she did not have buckling of knees or twisting of ankles. She is able to wear slippers, and there was no slippage of slippers, and there was no stiffness of limbs, no thinning of muscles, no history of pain, fatigue, and muscle cramp, no muscle twitchings. She was able to sit without a support, and she can lift her arms over her head and was able to tie her hair and was able to towel her head, and she is able to button her blouse but with some difficulty, and able to hold the pen but unable to write because of tremulousness for last 3 years. There was no history of weight loss or loss of appetite. She is able to perceive coldness of the ground, and she does not feel like walking on a cotton wool, and there was no numbness, no paresthesia of lower limbs. There was no worsening of symptoms in dark or while washing her face. She did not have history of vertigo or hearing difficulty or tinnitus, fullness of ears, no backward or forward falls, no freezing while walking, and there was no loss of balance while turning to sides. Now moving on to speech abnormalities, she was having this for last 6 years. Initially, her husband noticed a change in her slang, and there was a separation of syllables. Sometimes some syllables were explosive in nature while talking. She also had difficulty in pronouncing complex words, but there was no decrease in speech output. She was able to understand and reply relevantly. She did not have difficulty in reading newspaper. She did not have difficulty in finding words while talking. There was no difficulty in making food bolus in the mouth or difficulty in swallowing. There was no nasal regurgitation. There was no nasal intonation or nasal twang. And she had involuntary movements in upper limbs for last 5 years, which was a to and fro rhythmic movement in both wrist and fingers while reaching for objects, but it was not present at sleep or at rest. It is present while reaching the cup of tea, but not after holding on to it, and she does not spill the tea. She is able to hold and mix food particles, but has smearing all over the face if she is not concentrating while eating. There is no abnormal posturing or jerks. There is no loss of consciousness or alteration in sensorium, no memory or sleep disturbance, no delusion, hallucination, or emotional disturbances. There was no alteration in smell, no blurring of vision or diminished vision or difficulty in differentiating colors or night blindness. There was no drooping of eyelids, double vision, or no difficulty to move an eye in all directions. No loss of sensation over the face, and she was able to chew the food. She is able to close the eyes, lips, and there was no deviation of angle of mouth, no drooling of saliva, and has normal taste sensation. There was no hard of hearing, tinnitus, or vertigo, no hoarseness of voice or nasal regurgitation. She was able to move her neck in all directions and able to lift the shoulder. She is able to roll the tongue and push the foot backwards. No palpitation, dizziness while standing, or bladder or bowel incontinence. Moving on to past history. Over last 8 years back, she took a treatment for the same, and details were not available. There was no history of diabetes, hypertension, coronary artery disease, thyroidal illness, tuberculosis, HIV, or malignancy. There is no previous history of surgery or trauma. Personal history: she consumes mixed diet and has normal appetite, normal sleep, no habituations, and normal bladder and bowel movements. So this is family history. She belongs to third generation and second. She is a female, and her father developed the symptoms at around 45 years of his age, and he just had swaying and fine movement he also had dysarthria and involuntary movements in hand, but there is no documented treatment or diagnosis taken. His sister also had similar complaints, and she also developed from at the same 45 to 55 years of age. And his father's father also had similar symptoms, but no documented diagnosis. Her sister also has a similar complaint. Elder sister, she started developing symptom at the around age of 40. She has two kids, one of 12 years of age and another of 9 years of age, and they are asymptomatic. Menstrual history: she attained menarche at 14 years of age, has regular cycles with normal flow. She had full-term normal delivery, para to live to women, and the last childbirth was 9 years back, and no obstetric complications. Treatment history: treated 8 years back, but details not available. Currently, she was evaluated outside with an imaging. MRI was done and was started on multivitamins and advised genetic evaluation, so referred here for the same. So this is a timeline of her symptoms development. At 2014, she started developing imbalance in walking, which was minimal. And later, after 2 years, she started swaying while walking. And after 1 year, 2017, she developed speech abnormalities. Then progressed to involuntary movements in the hand. And then in 2019, she started requiring a walker or a chair to move around inside the house itself. At around middle of 2020, she could not even stand by herself. And at present, 2022, her symptoms still persist in the same way. So moving on to summary of history: 39-year-old female with no known comorbs, with a significant family history, presented with insidious onset chronic progressive neurological illness in the form of gait unsteadiness with dysarthria and tremors of both upper limbs for 9 years of duration, with current disability in the form of inability to stand or walk without support, and has illegible speech and clumsiness of hands without any other sensory, motor or other cranial nerve involvement or any systemic features.
Oh, thank you. Sharma sir, can I start?
We can start. Sir, we can start.
Okay. So what we do is we will go back to the slide sharing mode. So I would have preferred to go to the timeline first, you know, and just get some information. Okay, this is something which I always insist all the postgraduates to draw, because we usually work on unorganized data. So there'll be jumping of information. So if you draw a timeline, a lot of information you can get. One is where exactly the disease started. So this is called as the epicenter of the disease. I think we will refrain from asking questions at this age. So we are going to go in a very methodical manner. So the first is to epicenter, where exactly the disease started. For example, it could be in the basal ganglia, in the cerebellum, in the cerebral cortex, which is very important in making a final syndromic diagnosis. Second thing, you can look at the temporal course of the disease, for example, 2014 to 2022. So it's not a very rapidly progressive disease. And you can also look at the what exactly is the functional status of the patient at the end of the timeline. So she is not able to stand by herself and she is totally dependent. So now what we will do is we'll go back to the slides and we will do the symptom analysis. Bhagyalakshmi, we can go back to the slides. Okay. Yes, go further. Okay. So this is the first slide which shows the history of presenting illnesses. See, neurology is a very methodical and very systematic science. So what we, the clinicians do is to ask yourself certain questions. So the first question is, where is the localization of this particular symptom in the neuroaxis? Okay. So that is the first question. I will just tell you the questions first. The second question is, what are the substrates which are getting involved? The third question is the most important question. That is, what is a syndromic diagnosis? That means you have to identify the patient comes with a set of symptoms. You have to identify a pattern, generate a pattern out of that. And then you have to go to the etiological diagnosis, for which again you have to ask certain questions like, what is the onset, what's the progression, what's the symmetric, is there any systemic disease that can explain whether there is any family history, whether there's any epidemiological data, whether there's any exposure to drugs or toxins. So all these questions you have to ask, then probable pathological diagnosis, and then the functional status of the patient. So you have to answer all these questions. So we will have to put the time. For example, we should give ample time for Sharma sir, because you are going to gain much more from Sharma sir. So it is past 7:15. Maybe we will go up to say 7:45 or 8. So Sharma sir will have decent 1 hour. Okay. So we will go to the first question. What was the first symptom?
Imbalance of while walking, sir.
Okay, so imbalance while walking. So where will you localize? And before localizing, what should you know?
Before localizing, I should know whether it is because of a sensory involvement or afferent and efferent I have to go about. In afferent sensory or
No. What I meant is, see, first you have to know, because people complain of feeling of imbalance and true imbalance. Sometimes they will come and tell you that I have a feeling of imbalance, but it may be true, may not be true imbalance. So you have to ask one question, whether somebody else has observed he being having imbalance, or if it is this is just a feeling for him. If somebody else has noted, for example, this lady was asked why she's walking like a drunkard, that means that it's a true imbalance. Okay. The second question is, whenever you say imbalance, you point to something happening with the maintenance of the posture and gait. But sometimes it can be due to other issues like a proximal weakness. People can say that I have imbalance while walking. Even pyramidal weakness, sometimes they will complain that I have unsteady gait. So these two things should be asked and should be very clear. Otherwise, you will be unnecessarily investigating the patient. So you have to be sure that it's a true imbalance. And second thing, it is not due to causes other than the usual 3 causes. The third question is whether it's an organic imbalance or a non-organic imbalance. Whether it is present always, or is it present only when somebody is observing. And in the examination also, you will have to ask the patient to walk backwards. Okay, so these are the main basic questions you have to ask before localizing. Once you are convinced that it is a true imbalance, not a psychogenic one, not just a feeling of imbalance, not due to the other causes, then you can go ahead localizing. So now you can tell me what are the 3 main localization for imbalance while walking.
Sensory, vestibular, and cerebellum, sir.
Okay, cerebellum, sensory ataxia, or vestibular. So in this particular case, where do you think is the localization and why? See, whatever statement you utter, you will have to reason it out.
Yes, sir.
Okay.
She actually did not have any sensation of numbness. There was no paresthesia. She was able to find that the ground is cold, and she does not have feeling like walking over a cotton.
This I call the Atma approach, Nedi. What is not there, so this is it. Don't do like that. Just get to the positive symptoms and tell me why you think that it is a cerebellar ataxia or sensory ataxia or a vestibular ataxia.
She had imbalance while navigating through narrow passage, and she had abnormal swing bilaterally and drunkard gait. And she also has history of, there was no word. Yes, sir. All these things points out to cerebellar drunkard,
you
gait,
feel
white
it is
face,
the,
swaying,
okay, so you feel it is a cerebellar ataxia.
associated with
Then-
dysarthria
No,
and
no, don't go to that. Don't go to the next symptom. Don't jump. Stick to ataxia now. So you feel it is a cerebellar ataxia. Now you tell me why it is not a sensory ataxia.
there is no associated sensory symptoms like numbness or paresthesia. She was able to perceive the ground sensation. Temperature sensation was intact.
In other words,
And,
how will you differentiate a cerebellar ataxia from a large fiber neuropathy or a posterior column ataxia? On the cerebellar side, there are two things. One is dysarthria, other is nystagmus on examination.
Yes, sir.
It is not on history, but in examination you can look for nystagmus, but in the history, speech involvement is totally against a diagnosis of either a vestibular or a sensory ataxia. That is one thing. Then, suppose it's a posterior column ataxia, then you have to ask for what is L'Hermitage sign?
Lightning-like sensation while moving the head, sir. Sudden lightning-like sensation.
So when you flex the neck, there's a sudden electric shocks-like sensation running down the spine, which is due to the irritation of the posterior column or sudden depolarization of the posterior column fibers. So if that is there, it will indicate a posterior column. What is girdle sensation?
No.
So it's a band-like sensory feeling, usually seen around the trunk. It can happen anywhere. That also indicates a posterior column involvement. What is pseudoathetosis?
When the patient visual stimulus is removed, the movement involved.
Pseudoathetosis is when you ask them to outstretch the hand, there will be piano-like movement. Okay, like this. Slow writhing movements, not fast like this, but slow writhing movements. This is called pseudoathetosis, which is again due to a desensory loss in the upper limb. Then in the examination, joint and position sense getting impaired is a strong point in favor of a posterior column or a large fiber neuropathy. What will be the type of gait when there's a large fiber involvement or a posterior column involvement?
High steppage gait,
So
stamping.
it's a high steppage gait as opposed to the wide-based irregular gait that you can get in a cerebellar disease. So because of this point, the strong point in favor of cerebellar ataxia here is the dysarthria, which is the ensuing symptom. Otherwise, in a given case, you will have to mention all these points. The examiner should get a feeling that you have thought over these possibilities and these are the way you are reasoning it out to be a possible cerebellar ataxia. Okay?
Yes.
Is it clear?
Yes.
Okay, then come to your vestibular ataxia.
There was no associated vertigo or tinnitus or any oral fullness. She did not have difficulty while turning, does not lose balance while turning.
Okay, so one thing you have to remember is although a unilateral vestibular dysfunction can present with swaying, it will never present with ataxia unless it's a bilateral involvement. Okay? So before you commit on a patient with a ataxia, not just swaying to one side, then you have to invoke bilateral vestibulopathy. Acute vestibulopathy can present with the swaying, which can be only episodic, but chronic progressive ataxia. If you want to invoke the vestibular system, then it has to be a bilateral vestibulopathy. Okay. So the absence of ear symptoms and very unlikely that it's a bilateral vestibulopathy. So with reasonable safety, we can say that we can localize to the cerebellum. Now you should tell me which part of the cerebellum.
Since ataxia is present, I would localize both truncal and gait ataxia is there. I would like to localize on anterior vermis and paravermian region. And since dysarthria and other 5 movements are also affected in the examination. So I would like to localize to extension into anterior lobe of cerebellum also, sir.
See this anterior lobe, posterior lobe. It's very confusing.
Yes, sir.
So I will tell you how exactly you will have to decipher the cerebellum.
Okay.
So in the midline, you have got the flocculonodular lobe, which is phylogenetically the old part of the cerebellum. Okay.
Yes, sir.
So this is connected to the vestibular nuclei, and it is also getting input from the superior colliculus, that the eye movements. So mainly, flocculonodular lobe receives information from the vestibular nucleus and the eye system. That is why flocculonodular lobe lesions can present. They can also present with ataxia and eye movement abnormalities, especially downbeat nystagmus.
Yes, sir.
So posterior to that is a vermis. Vermis is the area of the cerebellum which is receiving information from all these things which you have told about. The vestibular system, the sensory system, the auditory system, and also we were talking about the cerebellar input from the spinocerebellar tracts. But the spinocerebellar tracts is getting information to the, there's just adjacent to the vermis, there's an intermediate zone. So that is the area which is receiving the spinocerebellar tracts. And then you have got the corticocerebellum, that's the most lateral part. Okay. So if you look at this, the flocculonodular lobe is called as a vestibulocerebellum because of its rich connections with the vestibular system. The vermis and the paravermium or the intermediate zone is called as a spinocerebellum because it is receiving afferents from the spinal cord and it is projecting to the medial inhibitory tracts, the corticospinal tracts and all. Whereas the corticocerebellum has connections only with the cortex. It is not receiving any information, sensory information from anywhere. So the eye system is connected, the vestibular system is connected, the spinocerebellar system is connected, and also the cortex. Then you have got all these dendrothalamic, rubro, those connections are there. But when you come to localization, you should at least know this much. And when you talk about the anterior lobe of the cerebellum, then you're talking about the limb movements. So when I teach, I usually teach that if you look at the fish has to maintain an equilibrium. So this equilibrium is maintained by the vermion. Okay. Then for that, for the synkinetic movement of the limbs, for example, the humans have the synkinetic movements of the limbs. Akin to that, the fish has got these fins. For that, develop the anterior lobe of the cerebellum. And then for human beings, we have got the neocerebellum. So because of this, anterior lobe of the cerebellum will present with a limb ataxia confined to the lower limbs. If you look for finger nose coordination and all, it will not be there. So in summary, when a patient is presenting with ataxia, we do not know the other attributes of the ataxia, whether it's a truly stance ataxia, or there's an associated limb ataxia, or there's an associated truncal ataxia, we don't know. As for now, we will localize it to the, which part of the cerebellum? To the midline cerebellum. Okay. So the vermis. Okay. Again, there's a discrimination between the caudal and the rostral vermis. We'll not go into those details, but at least we should know that the midline cerebellar lesions presents with disequilibrium, just like in the fish. So here, because we only have information about the imbalance or disequilibrium, we will first localize it to the vermian region. Okay. Does she have any eye movement abnormalities? Not so. So safely, you can say that the flocculonodular lobe may not be involved, because that is one area which can present with fixation defects, pursuit saccadic, although the posterior cerebellum also can present with saccadic defects and all. But for the time being, you just understand that there is no eye movement abnormalities. It is solely the symptom of ataxia, which we will localize it to the vermis. But it can also be due to the connections of the vermis to the brainstem. There's a question, why not the superior cerebellar peduncle? Because we don't have, at this point of time, we are not discussing about the upper limb incoordination or anything. We are just confined to one symptom of ataxia, of disequilibrium, or gait ataxia. Okay. So when you come to the other things, we will come to the superior cerebellar peduncle and all. But for the time being, what I wanted to stress is not the superior cerebellar peduncle, but the inferior cerebellar peduncle, which is connected to the most primitive part of the cerebellum, to the medulla, the vestibular nuclei and all. Okay. I think that answers that particular question, but we will definitely come to superior cerebellar peduncle later. So for the time being, the first symptom we have analyzed to the midline cerebellum, and we have reasoned out that it's unlikely to be a posterior sensory ataxia or a deep sensory ataxia, and unlikely to be a bilateral vesticulopathy presenting with a chronic progressive ataxia. It's clear. Okay, we'll go to the next symptom. Speech abnormalities. Okay. So where will you localize the speech abnormalities? You are muted.
Yes, sir. I would localize this to cerebellar only, sir, because she had a separation of syllables in a single word, and some syllables were explosive. So there were both scanning and staccato type of speech, and she also had difficulty in pronouncing complex words, sir. But
So what we will do is, Sharma sir will be going to the details of the cerebellar speech. My role is to localize the speech. So it's most likely a cerebellar speech because of the whatever you have described as slurring and staccato. Do you know what is meant by staccato?
and
I think it is better to refrain from answering when the discussion is going on. Okay. Yes.
yes, sir.
So which part of this, what is meant by staccato quality of speech?
Staccato, sudden explosiveness while talking, sir.
There's something called as a prosody.
Prosody.
Prosody is the ability to modulate your voice. So the prosody can be exaggerated as it happens in a cerebellar disease, or it can be a monotonous voice with loss of prosody as it happens in an extrapyramidal disorder. So that is the staccato quality. Or a monotonous speech because there is no modulation. So the staccato explosive quality, everything calls for a cerebellar speech. So localization of the cerebellar speech is to the see, when there is dysarthria in a suspected case of cerebellar ataxia, it is telling you that the cerebellar hemisphere is getting involved. Okay. So the localization given is in the left parafermian anterior part of the cerebellum. That is one localization. The other localization suggested is the right cerebellum because the left cortex is connected to the right cerebellum. However, you just know that there is a dominance, just as in the cortex for the cerebellum also. Although it's a controversial thing, many believe that it is a left cerebellar hemisphere. So whenever you find that there is a dysarthria, it is no longer a tract lesion, it's a cerebellar hemispheric disease. Okay. So because the speech is involved, you will localize it to the cerebellar hemisphere and to the left anterior paravermian region. Okay. So next slide. Involuntary movements in the upper limb. So to and fro rhythmic movements of both the wrist and fingers while reaching for objects. It is not present in sleep or rest. So what exactly did you mean by this? Now, to and fro movements means, did you mean like this?
Yes, sir. While present only during reaching the target, sir. So I suspected intention tremor.
Okay, so you feel it is an intention tremor. You should know the mechanism of the intention tremor so that you will understand it better. See, whenever you want to touch a finger, the cerebellum is the one which is planning the trajectory. The trajectory to touch this finger, okay? So normally what happens is when you want to touch, there will be micro oscillations in a normal person, but it will be corrected in phase and back to the trajectory. When there's a cerebellar disease, the first correction will be out of phase. Next correction will be still out of phase. So when the target is reached, it will be like this. Okay?
Okay.
So where will you localize this intention tremor? This intention tremor is a feature of the corticocerebellum.
Yes, sir.
It can also happen with the superior cerebellar peduncular affection.
Yes, sir.
Okay. So now we have got localization to the vermis, to the left paravermian speech area, and possibly to the corticocerebellum because of the intention tremor, because that is the one which is determining the planning and composition of movement, because any problem in the corticocerebellum will result in a decomposition of movement. It will produce dysmetria, dysdiadochokinesis, intention tremor. Whereas the intermediate part of the cerebellum will present with a limb ataxia and hypotonia. Okay.
Yes, sir.
So we have localized to the corticocerebellum. Then what's the next symptom?
That's all, sir. She had these three.
So, okay. So we have got a cerebellar localization, and it is affecting possibly bilateral because it's a symmetric disease. Okay, now we will come to the most important part of clinical medicine, that is to recognize the syndrome. So syndrome is defined as a constellation of symptoms and signs due to more than one cause. Okay, so what is a syndrome? This is a syndrome of ataxia. You have got syndrome of ataxia, you have spastic syndromes, you have got extrapyramidal syndrome. Okay, these are all syndromes. So this is a syndrome of ataxia. Is it a pure ataxia or ataxia plus? Is there anything to suggest that there are any other neurological symptom to suggest that something outside ataxia is there? Nothing is there. So it's a pure syndrome of ataxia.
Yes, sir.
Is it a late onset ataxia or a early onset ataxia?
Late, sir. Early.
It's a late onset ataxia. Anything above the age of 20, we call it late onset ataxia. So it's a late onset ataxia syndrome. Now we will come to the etiology. To find out the etiology, I will ask one question after another. You will have to answer. Is it an acute disease or insidious onset disease? Is it a subacute disease or a chronic disease?
Chronic, sir.
So it's an insidious onset. It's not acute onset.
Yes, sir.
Because if you have an acute onset, differential diagnosis narrows to a vascular or a demyelinating or a toxic or a traumatic.
Yes, sir.
Mainly vascular and demyelinating, acute disease. Okay.
Yes.
So this is an insidious onset chronic disease. When you want to call it chronic, it should progress for more than 1 month. If it is less than 1 month, then you call it a subacute disease. Okay. So this is an insidious onset chronic disease. Now we will come to the progression. Is it a static disease? Is it progressive disease or a relapsing remitting disease?
Progressive, sir.
It's a progressive disease. If it's a relapsing remitting, then you should think about some other possibility. Okay.
Yes.
Then the fourth question is whether it's a symmetric disease or an asymmetric disease.
Symmetric.
Symmetric disease. For example, atypical Parkinsonism is always symmetric as compared to idiopathic Parkinsonism. So symmetry of the disease is very important. Okay. Any systemic disease to account for this?
No, sir.
No systemic disease. Fifth question, is there in family history? Or fifth question, you have to ask for the exposure to drugs or toxins.
No exposures.
No exposure. Sixth question is whether there's a positive family history.
Yes, sir. Strong family history, sir.
Okay, there's a family history. So it is a chronic progressive symmetric disease, possibly because of an inherited cause. Okay.
Yes, sir.
Then we will come to the pathology. What could be the possible pathology in a degenerative disease?
It's because of abnormal cell lysis, due to abnormal accumulation of proteins leading to degeneration of the cells.
Okay, degeneration or accelerated apoptosis.
Yes, sir.
So these are the possible pathology. And lastly, what is the functional status of the patient now?
She cannot stand with even without support, sir.
Okay, so when you are asked what is your diagnosis, you should tell that, sir, I will first find out whether it is a true imbalance or not by asking the question whether somebody also has observed this. And also, I would like to know whether it's a disease mimicking an imbalance like a proximal muscle weakness or a pyramidal weakness. And also I would like to know whether it's an organic or non-organic. If I am convinced that it is a true imbalance, then first I will localize it to the cerebellum. Before that, I will tell why I am not considering the sensory ataxia and the vestibulopathies. The sensory ataxia, we have already told that speech is involved, and in the examination, I will look for nystagmus. There's no Lermite sign, there's no girdle sensation, there's no history of pseudoathetosis, there's no high stepping gait. Because of this, I feel that it is I will examine for joint and position sense impairment, but before that, I would still feel that it's a cerebellar ataxia, and bilateral vestibulopathy only will present with a chronic progressive ataxia like this. So within the cerebellum, I will localize the midline vermis, and because when I examine, I will look for limb ataxia and hypotonia, which will tell me that the intermediate zone also is getting affected. But as of now, there's a symptom of intention tremor, which I localize in the corticocerebellum, and because of the faulty correction of the trajectory. Okay, and the dysarthria I will localize to the left side of the cerebellum, left anterior paravermian region. So I feel it's a case of cerebellar ataxia, and I would call it as a late onset ataxic syndrome. And because it is a chronic progressive symmetric disease without any contribution by a systemic cause and a strong family history, I would think it is an inherited ataxia of a degenerative type. And the most possible etiology will be a free radical injury or an accelerated apoptosis, and the functional status of the individual is such that she is totally dependent for her activities of daily living. Okay.
Yes, sir.
So any other question you would like to ask?
Myself? Sir?
Yes.
Yeah.
Sharma sir is taking all the examination now, sir.
Yeah.
Okay. Please go ahead.
Just one question. Sensory ataxia, you said. What will the patient symptom if it is a sensory ataxia?
Sensory ataxia, patient might have paresthesia and other sensory abnormalities associated with ataxia, which is worsening in dark, and while washing face, when visual cues are removed, the ataxia worsens.
Okay. Can you say why it is worsening at night, dusk and dawn?
Because equilibrium is maintained by vestibular apparatus and cerebellum, and with sensory, vision, and vestibular helps in equilibrium. If one of at least two should be required for maintaining the equilibrium. If a patient already having sensory, if the sensory stimulus is removed, and when in dark, the vision stimulus is also removed. So with one component, the equilibrium will not be maintained. So it worsens during dark.
Okay. Shall I proceed with the examination, sir? Shall I proceed with the examination?
Yes, sir.
Yes. I will just make a comment that this worsening during night, is it not very practical these days? Who is walking in the night these days? So it's a very theoretical question. Okay, sir. Please go ahead. I am waiting to learn.
You continue.
Yes, sir.
Sir, thank you, sir, for the melodious class. Continuous, melodious it was. Thank you, sir. And content also very high. Thank you. I think you can go on.
Yes, sir. On examination, she was conscious, oriented, comfortable, and cooperative. She was well built and nourished, and afebrile. No pallor, icterus, cyanosis, clubbing, lymphadenopathy. Head to toe examination was unremarkable. There was no obvious neurocutaneous markers, no external markers of tuberculosis. Vitals, pulse of 78 per minute with regular rhythm, normal volume and character, or all peripheral pulses were felt, no radioradial or radiofemoral delay, no vessel wall thickening. BP on in right upper limb in supine position it was 118/72 millimeters of mercury, and in sitting position with 114/70 of mercury. In left upper limb supine position it was 114/72. Respiratory rate 17 per minute, regular thoraco-abdominal in type. She was afebrile. Moving on to neurological examination, higher mental functions. She's a right.
Just one minute before that, you said about neurocutaneous markers. What all things you should think of? What do you look for? More common things.
I'll be
Neurocutaneous markers.
telangiectasia in this case because I would like to rule out ataxia telangiectasia.
Yes.
And
More commonly something.
neurofibroma, I would like
Neurofibroma. What do you get it? What do you get there?
cephaloid spots and cephaloid macules and freckling of axilla.
Yeah, cephaloid spot is what is the size of it? Any idea?
Yes, 5 mm in prepubertal age and 15 mm in
5 centimeter.
Yes, 5 centimeter.
In an adult,
Yes.
less than 1.5 in children. Okay.
Yes.
Okay. One more, something related to brain, neurocutaneous markers. Something happens here. Sturgeober.
Yes.
Sturgeober. That is otherwise called encephalo trigemino angiomatosis.
Okay.
Okay. I proceed.
Higher mental function. She is a right-handed individual, conscious, oriented to time, place, person. Examination of speech and language. She had dysarthria with scanning and staccato type of speech, but word output was normal. No aphasia or dysphonia. Comprehension was preserved and repetition was present. She was able to read words but not sentences. She was not able to write because of tremor. She was able to name common objects correctly. Memory was intact, all immediate, recent, and remote memory. No delusions or hallucination. No emotional lability. MMSE score was 28 out of 30. Cranial nerve examination, olfactory, bilateral, it was normal. Optic nerve, visual acuity, field of vision, color vision, fundus were all normal. Oculomotor, trochlear, and abducens, extraocular movements was full. Pupil was 2 mm bilaterally. All like direct, consensual, accommodation reflexes were present. There was no ptosis or nystagmus.
Okay, I think at this point we'll stop and ask few questions because it may be useful for examination. Okay.
Yes, sir.
Now, anosmia. Tell me one or two conditions which is important from the neurological point of view. What is the commonest cause of anosmia? Bilateral anosmia.
Any cortical lesions, sir?
No. Bilateral anosmia, common condition.
Nasal block, sinusitis.
Sinusitis or rhinitis. Okay, upper respiratory infection. Then other causes, neurologically related.
Any frontal base of tumors in the frontal region.
Yes, compressing on the olfactory tract and bulb. Yes, very good. Then
any trauma.
something related to some degenerative conditions. One of them almost always accompanied by anosmia. Parkinsonism. Parkinsonism, idiopathic Parkinsonism almost always is associated with anosmia. In fact, very often precedes. If there is no anosmia, you have to think of Parkinson plus or atypical Parkinsonism. Other condition is Alzheimer's disease. Alzheimer's. Okay. Can you relate anosmia to a traffic accident?
Yes, a cribriform plate damage.
Yes. What symptom they can have?
Rhinorrhea, sir.
Yeah, CSF rhinorrhea. Very great. Now in the optic nerve. You tested the visual acuity, field of vision, color vision, fundus.
Yes.
Okay. Now, field of vision, what is the method used?
A perimeter is there, sir. Confrontation test.
Bedside.
Confrontation test.
Pardon?
Confrontation test.
Confrontation test. Okay. Can you tell some of the abnormalities of the field? All can be asked in the examination. Start from the anterior part, go posteriorly, one after another.
Scotoma.
Starting from the, I will start optic nerve lesion. What will you get? Optic nerve lesion.
Anopia, sir. Unilateral.
No, vision. Optic nerve, if there is a compression or some damage to the optic nerve, you can get a unilateral visual loss. Only one side.
Yes, sir.
If the patient has got a right-sided involvement of optic nerve, if he closes the left eye, he will not see anything. Are you following it?
Yes, sir. Yes, sir.
Very often, sometimes may not be found out because he is using both eyes. We always use both eyes. So if you close one eye, the other eye, you will find he becomes totally blind. That is how they come to know that there is a blindness on one eye.
Yes, sir.
Okay, then
corneal
come to the chiasm.
Chiasma, there is hemianopia, sir.
No, chiasm chiasmation is characterized by heteronymous hemianopia. You have heard about a homonymous
Yes, sir.
and heteronymous. Homonymous hemianopia occurs in retrochiasmal lesions. Homonymous hemianopia occurs in retrochiasmal lesions. I will explain that. When there is a compression of the optic nerve, what is the common condition which produces compression of the chiasm? What is the common condition that produces compression of the chiasm?
Pituitary tumor, sir.
Pituitary tumor. Or Rathke's pouch cyst coming from above. That also can produce. Now, when it is happening, the crossing nasal retinal fibers are vulnerable for compression. You know, the nasal retinal fibers are looking at the temporal field. So when the nasal retinal fibers are affected preferentially, you will find both the temporal fields are cut off. It produces it produces bitemporal hemianopia. Bitemporal. It's very classical.
Yes,
And it comes under heteronymous hemianopia. Now you told about the homonymous hemianopia. What do you mean by homonymous? Why is it called homonymous hemianopia?
If a optic tract is affected, sir,
Agreed.
the nasal fibers which is carried, which crosses over along with the temporal fiber of the opposite side, if it is cut off, then we'll not be able to see the half of the vision, sir.
When you say left homonymous hemianopia, which are the fields that are involved? Left homonymous, just think and answer. Even if it is wrong, doesn't matter. I will correct it. Left homonymous hemianopia. It's not an examination, it's only teaching. Left homonymous hemianopia.
The nasal fibers of the right side and the
field. You should talk about a field. Homonymous hemianopia means homo means same. Are you following it?
Yes,
you
sir.
get left temporal field is lost and right nasal field is lost.
Yes.
So that, why is it called homonymous then?
Same side, left and left, while on vision, while
that is because the field is lost in such a way that left half of the field of the left eye. What is the left half of the field of the left eye? So you got a like this.
Yes, sir.
Cut like this. This part is left half. So the temporal.
Yes, sir.
Okay. For the other eye, left half is nasal. So left half of the field of the left eye and left half of the field of the right eye.
Yes.
Therefore, it becomes both are left. There it becomes homonymous hemianopia. Homonymous hemianopia. Are you following it?
Yes.
One nasal field and contralateral side, it is a temporal. But it is because left homonymous means left half of the field of the left eye. Are you following it?
Yes, sir.
And left half of the field of the right eye. For each eye, you have got two fields. What is the left half of the field of the right eye? Which field?
Left half of the field of the right eye, which is this side, sir.
That is nasal. You should say nasal. Right nasal and left temporal.
Yes.
Okay.
Yes.
That will occur when there is a retrochiasmal lesion. So when you got a retrochiasmal lesion on the right side, in other words, retrochiasmal lesion produces contralateral homonymous hemanopia. So if it is a left optic tract lesion, it will produce right homonymous hemanopia. And if it is the right optic tract lesion, it will produce left homonymous hemanopia. Are you following it? So generally it is stated that it is a retrochiasmal lesion. So after the optic tract, optic tract, what is the next structure? What happens? Yeah.
Optic radiation, sir.
Optic radiation. That starts from the lateral geniculate body. Okay. Otherwise called, the fibers are called geniculocalcarine fibers. Are they going together? Optic tract is coming like this. These geniculocalcarine or radiations are going together or separated?
Separated. They have layers.
Yeah, layers, but are different. One is going through the parietal lobe, higher up. Are you following it? You got a lateral geniculate body here. One is going at a higher level, other one is going through the lower level. Lower level is going in the inferior radiation, that is in the temporal lobe. And where you in the upper lobe, it is upper part, it is a parietal lobe. Are you following it? So single lesion can produce, optic tract lesion can produce homonymous hemanopia. But you cannot have a patient usually who has got a right temporal is completely lost and right parietal also lost. So what is the classical manifestation of the field of vision when there is a temporal lobe involvement?
Quadrantopia, sir. Superior quadrantinopia.
How will you full answer you should say? It's a right temporal lobe. Because the right side, it has to be left. So left, it has to be homonymous.
Yes, sir.
Okay. Temporal lobe is below or above?
Below, sir.
Below. So when the light is going through the lens in this manner, diagonal manner. Therefore, upper part will be
lower part.
Upper field goes to the lower retina, lower field goes to the upper retina.
Yes.
So when the right temporal lobe is involved, it produces left-sided homonymous. That is again part of the temporal portion and nasal portion. Left half of this side, left half of this side.
Yes.
So left homonymous quadrantinopia.
Yes,
Quadrantinopia. Other name is, there is one more popular term, pie in the
sky.
Pie in the sky. Pie in the floor indicates
Parietal lobe.
Parietal lobe lesion. Are you following it?
Yes,
so parietal lobe lesion, right parietal lobe lesion will produce what?
Left.
Right. Just think and answer. Right parietal lobe.
Left superior homonymous quadrantinopia.
Why do you say superior? This is the upper part. Temporal lobe was in the lower part.
Inferior. Yes, sir.
So it will be left homonymous inferior quadrantinopia. Okay. Now, so therefore, it is not possible for a homonymous hemanopia to occur unless both cerebral hemisphere, both temporal lobe as well as parietal lobe are involved.
Yes, sir.
Are you following it?
Yes.
That will not happen because the patient will be dead. Now, occiput lobe, if that is also involved, you will also get
macular sparing.
contralateral homonymous hemanopia. There are some features which are peculiar to occipital lobe lesion, occipital lobe hemanopia.
Macular sparing, sir.
Macular sparing. Then anything else? There is something called a congruous and non-congruous. You should remember like this. MCH, macular sparing, congruous, crescent sparing. You can just take down if you want. Macular sparing, crescent sparing. Okay.
Yes, sir.
And congruous. Congruous means if you, so right-sided lesion, you have got a left temporal and right nasal. So if you superimpose the nasal field of vision that is lost, put it on here, it will be exactly same. So congruous means suppose the shape is like this, the other side also, the nasal also, it will have the same shape. So exactly same nature of the field. If you map out the field, you can do it. You will find exactly the same. Then you call it as congruous. Congruous occurs when there is a posterior lesion. So occipital lobe will produce macular sparing, congruous, and there is also crescent sparing. That I am not going to tell you, you will get confused. And homonymous myopia. Just write, think MCH. That will be the clue. Now, from the field, you should go to fundus. What is the importance of looking for the fundus?
Fundus, any retinal degeneration is associated with ataxia, sir.
Pardon?
Retinal degeneration.
Yeah,
Can
one
be
is retinal
associated.
degeneration. What type of retinal degeneration? Many disorders are associated with the retinitis pigmentosa.
Pigmentosa. Yes.
Pigmented degeneration, A beta lipoproteinemia, many of these spinocerebellar ataxia, lot of things can be associated with that. Are you following it?
Yes, sir.
Then anything else? What are the usual cases? What are things you will notice when examining?
Optic disc,
Optic disc you will note,
optic
arteries
failure,
you will note, veins you will note.
and
Is
the-
there any pigmentation?
yes, sir.
Everything, any abnormality should be identified. Now, what is the importance of looking for the disc?
Disc color of pale of the disc diameter.
The
And
most
then
important thing,
edema,
somebody comes with a headache and vomiting,
papilledema.
papilledema. Papilledema refers to the disc swelling.
Yes, sir.
Are you following it?
Yes, sir.
So papilledema, disc swelling or blurring of the disc margin is not always due to papilledema. There are a lot of differential diagnosis. I am not going to that. For the blurring of the disc margin. Blurring of the disc margin can occur in other conditions also, but one or two findings which will favor that the patient has got a papilledema when you find blurring of the disc margin. One, the lamina fibrosa will appear full. You know what is lamina fibrosa? In the center part.
Yes, sir.
Yeah, that will appear full. Number two, there will be slit-like hemorrhage or splinter hemorrhage. That's also called splinter hemorrhage because the high pressure, small vessels will rupture and produce bleeding. And loss of spontaneous venous pulsation. This is one area where arteries do not pulsate. Do the retinal artery pulsate? No. It is the vein that is pulsating. Loss of venous pulsation, spontaneous venous pulsation, which is normally present in 85% of the people. Are you following it? When you look at the retina, you will find the venous column is pulsating. 85% of the people have it. 15% only normally do not have it. So when you have got a loss of venous pulsation of the retina, that's also a point in favor of papilledema. Are you following it? Blurring the disc margin, slit hemorrhage or splinter hemorrhage, and loss of venous pulsation. Are you following it? These are the few clues to say that it is a papilledema. What is the field of vision you get abnormality in the field when you have a papilledema?
Central scotoma, sir.
Pardon?
Central scotoma.
Concentric constriction of the field. Concentric constriction. Are you following it?
Okay.
So from the we will move to what is optic atrophy.
Failure in the
That's
disc.
also important. Many neurological conditions will be associated with optic atrophy. So if there is a left optic atrophy, patient will have a left-sided visual loss, unilateral visual loss. Okay. In that situation, you elicit a sign. What is that sign? With a torch. Have you heard RAPD?
Yes, sir. Swinging flashlight.
Yeah, Marcus gun
Gun
pupil.
pupil.
Are you following it? Can you just tell what is Marcus gun pupil? If there is a right optic nerve lesion or disc is atrophic.
There won't be both the direct and consensual reflex while passing light over the respective eye will be lost, sir. But the consensual reflex present while swinging the light, when the light enters the opposite eye, the consensual reflex over the other eye will be present.
Okay, you can put it like this. So when you switch over from one eye, it will constrict. The other would have constricted. Indirect response.
Direct reflex.
When you switch over from this side to that side, direct response will be greater. Therefore, it will again further constrict. So if you switch from left side to right side, right side also will constrict. So when there is a
Optic atrophy.
optic atrophy here, This is called, what is that called? Test.
Swinging flashlights.
Swinging flash test of Levadity. Levadity swinging flash test. So you switch over like this. When you do that, this is a paradoxical dilatation of the pupil on the involved side. Are you following it?
Yes.
Paradoxical dilatation. Suppose there is an optic atrophy here. When normally, when left to right, if you switch over, you will find this will constrict. So when you switch from left side to the right side, the right is contract. When you are throwing light here, left side,
Yes.
so it is having direct response. This side is having indirect response. Are you following it?
Yes, sir.
Are you following it?
Yes, sir.
Yeah. From when you switch over from left side to the right side, the direct normally will cause further constriction. And it cannot, because light is not entering the retina,
Dilatation.
in the nerve, brain is not entering. Therefore, you will find there is a paradoxical dilatation. So you can just say that it is paradoxical dilatation of the pupil on the involved side when you switch over from the normal to the abnormal
Yes, sir.
in performing swinging flash test. Okay.
Yes.
Now we go to the, yeah, I think you go to the extraocular ones. Now the extraocular muscles, what is the early symptom of extraocular muscle palsy? Earliest symptom. Earliest symptom. Suppose somebody has got a right lateral or left medial rectus, right lateral rectus, superior rectus. What symptom they will have?
Diplopia, sir.
Diplopia. What is the type of diplopia? So when you have a diplopia, you have to decide whether it is a uniocular diplopia or binocular diplopia. You got any idea about it? So very important.
If one eye is closed, the affected eye is closed, the diplopia will not be present, which means it's unilocular.
Okay. The better way of saying is uniocular. This is important. Uniocular diplopia is always ophthalmic cause. Always ophthalmic cause. Binocular diplopia is always
Brainstem.
neurological.
Neurology.
So if you get binocular diplopia, we will send the patient to Anand Kumar. Otherwise, uniocular diplopia, we will send to ophthalmologist. What is the mechanism of binocular diplopia? I will answer. Normally, when I am looking at you, my eye is turned to your side, left eye, right eye, both. Now the light is traveling like this, and it is falling on the macula. If you want to have a clear vision, the macula, lens, and the object should be in the same line. Are you following it like this? Okay. So your aim of looking at an object is to make the macula in alignment with the object. So normally, I will move only conjugately. Are you following it?
Yes,
It doesn't move alone. If you are turning right gaze, if you are performing, you will find both of them are moving to the right side equally with precision. So the aim of that will be to make the
fixate the object.
Object, the image fall on the macula. So clarity of vision will occur because macula has got the highest acuity vision. Are you following it?
Yes,
Now, suppose a muscle is paralyzed. This is left lateral rectus. This is right, left medial rectus and right lateral rectus. I am looking to the right side. So when I am turning the eyeball to the right side, right lateral rectus will contract to the equal degree, same precision, left medial rectus also will contract. What is that called? They are called yoke muscles. Suppose there is a right lateral palsy, right lateral rectus palsy. So this is not, my right hand is this is not moving, whereas this is moving. So this is in line with the
axis,
object, lens, and the macula.
yes,
It should have moved like this. This side, this hand or this side should have moved. It has not moved. It has fallen short of the stipulated area. That is, it should have got abducted. It is not abducting. It is actually slightly medially rotated. So you will find the images on the right eye is not falling on the macula. On the left side, it is falling on the macula. On the right side, it is falling on another area, non-macular area. So when there is a rule that Actually, when you are seeing me, there is a one image in your retina left eye, another image on the right eye. Why are you seeing as one?
It all converts into electrical stimulus and joins together in.
No, it is because of the occipital lobe function. Occipital lobe will fuse the images. If the occipital lobe function is this, it will fuse the images. Even though we are having two images, it will fuse into one. That is the function. This will happen only if the images are falling on corresponding points of retina. Corresponding points are retina. So when normally you are looking at a particular object, images fall on the macula, this side and that side. Therefore, it is falling on the corresponding points. Whereas one eyeball is lagging behind because of muscle paralysis or any other matter, you will find it is falling on the macula one side, non-macular area on the other side. This is called non-corresponding points. So when it is falling on the non-corresponding points of retina, the occipital lobe cannot fuse it. Now, patient have got a diplopia, one looking to the right side. If you close the right eye, what will happen? Binocular diplopia. There is only one image here, falling on the left eye. So there is no need for diplopia. So patient will, the diplopia will disappear. Now, if you close this eye, what will happen?
They can perceive the image.
If you close this eye, again, there is no diplopia. So binocular diplopia will disappear whether you close the left eye or the right eye. Are you following it?
Yes, sir.
Close this eye, no diplopia. Close this eye, no diplopia. So binocular diplopia is neurological. It is because the images are falling on non-corresponding points of retina and the occipital lobe is unable to fuse it. Are you following it?
Yes, sir.
Yeah. Then unifocal diplopia, what you should understand is it's always a problem of refraction and also iris tear, subluxation of the lens. Subluxation of the lens is important from Marfan syndrome. It is important. You can have a case. Therefore, here what happens is, suppose there is an iris tear. Normally, there is only one aperture.
Yes,
so it will act as a single lens. So when there is iris tear at the periphery, which classically produces a iridodialysis with a D-shaped pupil. So you have got a one central hole. Now it is D-shaped, whereas there is another hole in the root of the iris. So it will act as two lenses. Are you following it?
yes.
So this will send light like this to the retina. This also will separately send light to form another image.
Yes.
Now, such a patient who has got a left-sided iridodialysis, if you close the right eye, what will happen? Diplopia will persist or diplopia will disappear. Because left eye, patient has got iridodialysis, there are two images. Are you following it?
Yes, sir. Will persist.
I am closing the right eye.
Will persist.
It will persist. Now I close the left eye. Then
it will disappear.
It will disappear. So monofocal diplopia is
Ophthalmology.
identified by disappearance of the diplopia by closing the abnormal. Are you following it?
Yes.
So it's always neurological for binocular diplopia. Now, just to tell few actions of extraocular muscles. What is the action of superior rectus?
Upward gaze, sir. Pushes the.
It's an elevation.
Yes, sir.
Then there are three components you have to mention: elevation, intorsion, adduction or abduction.
Superior rectus is abduction, sir. Recti adductor.
It's an adduction.
Adduction.
It is adduction. There is a diagram in the
Yes, sir.
Hutchison. You can draw it and learn. Okay. So it's an elevator. It's an intortor. And also is an adductor. Inferior rectus.
Depressor. Extorsion.
Extortor.
And adductors.
Adductor. Recti are adductors. Obliques are
abductors.
Abductors. So what is the action of superior oblique?
Superior oblique, extorsion.
superior. Both superiors are intorters.
Daughters.
Both inferiors are extorters.
Extorters.
Are you following it? Both recti are adductors. Both oblique are abductors. Okay. Both superiors are
Intorters.
daughter. Both inferiors are extorter. So superior oblique will be depressor or elevator.
Superior will be depressor.
Depressor. Okay. Then it is a intorter.
Daughter.
They're not. And then abductor.
Abductor.
Okay. When you analyze the diplopia, it is very important to have resolve the action into the elevation depression. Suppose you got a lateral rectus, medial rectus, very easy. Lateral rectus, abductor paralysis, easy to find out. When there is a superior rectus paralysis or a superior oblique paralysis or inferior rectus inferior, they are elevators or depressors. They're not. So there is a paralysis of one of these muscles. There is a simple way of identifying. That is called Maddox mnemonic. MADDOX MNE Are you following it?
Yes.
So I am not going to the mechanisms of it, but what I am going to give is just a tip. When the patient is looking in the direction of the right superior quadrant, this is my right superior quadrant, right inferior quadrant, left superior quadrant, left inferior quadrant. So easy way of identifying is ask the patient to look to the right superior quadrant. Only two muscles are acting when the patient is looking in the right superior quadrant. The muscles are, it can be easily remembered, right superior quadrant. You write RSQ, capital RSQ, right superior quadrant. Take the corresponding rectus. What is the corresponding rectus? RSQ, right superior quadrant. What is the corresponding rectus? Right superior rectus.
Yes.
RSR. Okay. Now, next step is take the most cross-named letters. That means right for left, superior for inferior, rectus for oblique. Are you following it?
Yes.
So right upper quadrant, you will find muscles acting are right superior rectus, left inferior oblique. Now you tell about left inferior quadrant using the same principle. Can you just try?
Yes, sir.
Left inferior rectus.
Left inferior rectus, right superior
Oblique.
oblique.
This is all what you should know.
Yes.
Then there are two things more. There is a rule of diplopia. So when the patient has got a diplopia due to muscle paralysis, there are two images. You get two images. One will be outer, other will be inner. Are you following it?
Yes.
Diplopia is, first rule, diplopia is maximum when the patient is looking in the direction of action of muscle. So when somebody says diplopia, I am seeing two images. You ask the patient whether it is right upper quadrant or in the horizontal gaze, right or left, or right inferior quadrant, or left superior or left inferior quadrant. So if you have got diplopia maximally, maximum diplopia in the particular quadrant, maximum diplopia means maximum separation of images. Maximum diplopia means maximum separation of images. So when that happens, if it is found in the right superior quadrant, the muscles that are likely to be paralyzed will be,
Right.
I told you two muscles, right superior quadrant,
Right superior rectus and left inferior oblique.
left inferior oblique. Now you must find out whether it is a right superior rectus or left inferior oblique. Now how will you find out that? You close. Yes, correct.
In adductor position, if it is
Pardon?
in adduction position, if it is increasing.
No, that's not. There are two images here. Okay. One is outer. Can you see the two fingers?
Yes, sir.
I close the right eye. Right eye. So the outer one disappears. Which is the muscle that is acting from the right eye?
Left inferior.
No.
Right eye.
Right superior rectus. We have told the mnemonic right superior rectus and left inferior oblique.
Yes, sir.
So you find out by closing which eye, the
Right.
outer image disappears.
Right
I
superior.
close the right eye, close like this. So the outer image disappears. Outer image always belongs to the abnormal eye. That is the second rule that I forgot to tell.
Okay.
First rule is maximum separation of images occur when the patient is looking in the direction of action of muscle. Are you following it?
Yes, sir.
Now, the outermost image will always be the abnormal one. That is coming from the eye which has got a paralysis. So if it is like this, when I close the right eye, the outer one disappears. So
Right.
what is the muscle that is working from the right eye?
Right superior rectus.
Superior rectus. On the other hand, when I close the left eye, it disappears. It is
Left inferior oblique.
left inferior oblique. This is how you resolve when there is a single muscle paralysis. But this is not applicable when there are multiple nerve palsy, third nerve, so many things are there. So it is not applicable. So when there is a lateral rectus palsy or superior rectus palsy, oblique, single muscle, this can be used. This is called Maddox mnemonic. And the rule is very simple. Okay. Now, what about the pupil? What is the importance of looking for pupil?
Pupil, whether it is meiosis or mydriosis, we have to.
Can you tell 2-3 causes of anisocoria?
Third nerve,
Anisocoria means size is different. One, it can be
superior colliculus lesion. Third nerve,
superior. Yeah, one is third nerve lesion,
Lesion.
different. If the right optic nerve is damaged, it
Damage.
will produce afferent problem. That also will, that is called amaurotic pupil. If there is a right optic nerve lesion, right pupil will be dilated because it is the light is not entering the right retina or right eye. Are you following it?
yes.
Therefore, right optic nerve lesion, you will find it is larger than the left. This is called amaurotic pupil. Are you following it? If there is a efferent problem, that is the Edinger-Westphal nucleus, the parasympathetic fibers coming out are affected. You find efferent problem. That is what happens in third nerve paralysis.
Yes.
Are you following it? Some of the, there is no paralysis or anything. Patient comes with some dementia or other neurological problem, inability to walk, stamping gait and all that. Then you examine the pupil. You know what is stamping gait?
Yes, sir. Stamping.
What is that? Stamping gait occurs in sensory ataxia, particularly tabid dorsalis.
Yes.
Tabid dorsalis. What is the pupil? Can you describe?
Argyll Robertson pupil.
Argyll Roberts. Can you describe that?
Relative afferent, there will be light near dissociation in Argyll Robertson pupil.
Correct. Light near dissociation. Light near dissociation classically occurs in tabid dorsalis. It also can occur in dorsal midbrain syndrome. There are a lot of causes. Dorsal midbrain syndrome. Dorsal midbrain syndrome, typically Paranoid syndrome.
Paranoid. Yes, sir.
Paranoid syndrome. Are you following it?
Yes, sir.
So the light reaction will not happen. What is the other benign condition where the light reaction will not happen? There is a benign condition which is associated with areflexia, commonly in females. It doesn't react, but it is not going to produce much harm, just like tabes. Tabes, light reaction is absent, accommodation is present. Have you heard IDS pupil?
Yes, sir.
Yeah, IDS people also mimic it, but only thing is it takes longer time. There is a inertia of contraction as well as inertia of dilatation. So that patient also will come to you with a anisocoria. That's also another cause for anisocoria, not a common thing, but more common than tabid dorsalis. Okay.
Ciliary ganglion damage.
Pardon?
Ciliary ganglion damage.
Yeah, agreed. Fully agreed. Now you go to the next slide. Did you understand what I've been telling?
Yes, sir.
Yeah. Then trigeminal nerve,
Oh,
sensory
motor
tested,
and-
everything is normal because these things are normal. Some questions I have to ask. When you test the sensory, okay,
Yes.
when you test the sensory, you will touch here near the midline or away from the midline. Near the midline or away from the midline, away from the midline, somewhere in periphery.
Over the
You should not touch here. What is the nerve supply here? Nerve supply is C2, auriculotemporal. Are you following it? So by touching here, you should not think that you are testing the sensory loss in trigeminal distribution. Trigeminal distribution will come like this, here, and lateral part is from the cervical C2, auriculotemporal nerve. So when you are testing like this, test near the midline. If you go here and test, if it is lost, it is C2 lesion. Are you following? Or the nerve lesion, auricular temporal. In trigeminal lesion, this will be normal. So you should not test it here. Are you following it?
Yes.
Okay. Now go to facial. What is the difference between the upper motor neuron facial palsy and lower motor neuron facial palsy? UMN facial, LMN facial. Just
Element,
points.
yes, a human has bilateral innervation, therefore the occipital frontalis supply, the upper part of the upper half of the face is preserved, whereas in element it is lost, sir.
Okay. In UMN lesion, the paralysis occurs in the lower part.
Lower part.
In LMN lesion, it occurs in the upper part as well as lower part. What is other finding you look for? Some phenomenon.
Bell's eye phenomenon. Sir.
Bell's phenomenon. What is Bell's phenomenon?
Rolling of eye over while close.
Yeah, rolling of eye. It will not occur in UMN paralysis. It will occur in only in LMN lesion. There is also something called a mimic paralysis or mimetic paralysis. Mimetic paralysis or mimic paralysis. That is the emotional component. When somebody is moving, suppose I am asking you to show the teeth. Patient shows the teeth like this. That is voluntary. But when you are crying, when you are laughing, at that time also there is a movement. In UMN lesion, patient have got a paralysis of the left side, lower part is paralyzed, therefore it is UMN. Ask the patient to show the teeth, there will be paralysis. This side will move, this side will not move. But in that patient, if the patient is crying or happy, hello doctor, I am improving, I am going home. He is happy, he is smiling. So at that time, that even though there is a paralysis in UMN, the lower part, emotional component will be spared. That is the feature of UMN facial palsy. So I will repeat, UMN facial palsy is characterized by involvement of the
Lower half.
only lower part. Number 2, Bell's phenomenon will be absent. Number 3, it will spare the emotional component. Are you following it?
Yes,
Whereas the LMN, it is all, everything is affected. Upper part, lower part is affected. Bell's phenomenon is present. And emotional component also is lost. Are you following it?
yes, sir.
Okay, now we go to 8th. Okay. Now something about nystagmus also I will ask you. Can you differentiate between, this is important for this case. Did the patient have nystagmus? No.
Sir.
Did not have?
No, sir.
No. How do you classify nystagmus? Some few points. What is a phasic nystagmus? What is the pendular nystagmus?
Pendular nystagmus, both the components have equal velocity, whereas jerk nystagmus, one is slow component, the other is a fast.
Correct. Very good. Very good. Jerk nystagmus is other is called phasic nystagmus. Pendular nystagmus is characterized by same velocity in both sides, whereas the jerk nystagmus or phasic nystagmus is a rapid phase and a slow phase. Look at my hand, rapidly, then slowly, rapidly, then slowly. And how do you give direction to the nystagmus?
Fast component gives a direction.
Fast component is decided. Yeah, that will decide the direction. It is beating like this to my right side, it is nystagmus the right side. If it is beating left side, it is nystagmus the left side. What is the classical nature of a cerebellar nystagmus? There are a lot of nystagmus named in cerebellar lesion, but classical, most common.
Gaze evoked nystagmus.
Gaze evoked nystagmus. How do you test for gaze evoked nystagmus?
While
Just few precautions. Yes.
certain gaze, while moving to a certain gaze, they'll develop nystagmus because
Ask the patient to look at object which is held in the periphery. You should not go to too much of extreme. So 30 degree away from the midline, ask the patient to hold like this. Then patient looks at the object 30 degree from the midline and finger is kept roughly 1 foot away from the nose. Are you following it? 1 foot away, 30 degree away from the midline. That is the ideal position. If you go to the extreme, what will happen?
end gaze nystagmus.
End nystagmus, which is physiological. You should not mistake it for abnormal nystagmus. You should not produce it. So when you test it, 30 degree away and 1 foot away from the patient's eyes. Are you following it?
Yes, sir.
So what is meant by gaze-bound nystagmus? Where is the quick phase? Where is the slow phase? Whereas the cerebellar nystagmus will be characterized by when the patient is looking to the right side. When the patient is looking to the right side, are you able to follow? Clear?
Yes, sir. Yes, sir.
Yeah. When I am looking to the right side, cerebellar nystagmus will be quick phase to the right side. Are you
Yes,
following it?
yes, sir.
Now, when I am looking to the left side, what will happen? The quick phase will change. Quick phase will be to the left side. In other words, nystagmus to the point of fixation. What is the point of fixation when I am looking to the right side? It is right side.
Right side.
So if you write, just take down nystagmus to the point of fixation. Nystagmus to the point of fixation. So if you look at the right side, quick phase is right side. If you look at the left side, quick phase is to the left side. Okay, that is number one. So if you look like this, quick phase, slow, quick phase, slow. And what about the primary position? Looking straight,
No, no nystagmus.
there will not be any nystagmus. So that is the classical nystagmus of cerebellar region. Now, in contrast, patient with the vestibular lesion. If the patient has got a right vestibular lesion, patient will have nystagmus beating to the left. Whether the patient is looking to the left, whether the patient is looking straight, and whether the patient is looking to the right side. I will repeat. If you have got a right vestibular lesion, when the patient is looking to the left side, the quick phase will be to the left side. When the patient is looking straight, there will be nystagmus, there can be nystagmus, the quick phase will be to the left. When the patient is asked to look to the right side, that is the side of the lesion, again the quick phase will be to the left side. So the quick phase is contralateral to the lesion. So the direction will not change. Whether the patient is looking to the left, looking straight, or looking to the right, the nystagmus direction will be contralateral to the side of lesion. Whereas in cerebellum, you find looking at the right side, quick phase to the right side. Looking to the left side, quick phase is left side. Are you following it?
Yes, sir.
That is the feature of a vestibular nystagmus. And vestibular nystagmus, if it is acute, will be accompanied by nausea, vomiting, and vertigo. Vertigo, nausea, vomiting. Are you following it? These are the main major differences. Now you go to the next side, facial, vestibulocochlear, glossopharyngeal. Okay. Yeah. What is the type of dysarthria you have? This patient had? No.
She had, sir. She had dysarthria.
Had.
Yes, sir.
Okay.
Ataxic type of.
Okay. Staccato, and we already discussed that. We will not waste time with that. Now come to the okay. Now come to the motor system. Yeah. Continue.
Yes, sir. Motor system examination, bulk, there were inspection, there was no obvious wasting. Measurements were all normal. Upper limb tone, there was hypotonia in bilateral upper limb and lower limb.
How do you test the tone?
Tone is
Passive full range. You can take down. Passive full range movement. It should be passive. Patient should not contract. Ask the patient to relax. Okay. When the patient is relaxing, you do the passive movement. It should be full range. You cannot do like this. Short distance not. It's full like this. Whenever doing, if you are doing adduction, abduction, it should be like this. Okay.
Yes.
So
passive.
full range, passive movement. Okay.
Yes.
Now, what are the types of tone abnormalities you can get?
Hypertonia, hypertonia.
Okay. What are the types of hypertonia?
Spasticity and rigidity.
Okay. What is the difference between spasticity and rigidity?
Spasticity, when present only in the anti-gravity muscles or any one compartment of the muscles will be there. Rigidity, there will be hyper.
Spasticity is selective. You got a pyramidal, extrapyramidal. Pyramidal is selective.
Yes.
So, which are the muscles that are hypertonic in the upper limb? Which are the muscles that are hypertonic in the lower limb? In a pyramidal lesion.
Pyramidal upper limb, it is flexor because it is anti-gravity muscle, and in lower limb, it is extensor.
No, which are the anti-gravity muscles?
Flexor.
Easy way of remembering is, you know the hemiplegic posture?
Yes, sir.
Hand like this.
Adducted.
So, imagine that the upper limb will be adducted,
Flexed.
internally rotated, flexed here, pronated. So these are the muscles that are hypertonic. Are you following it? Increased tone occurs in adductors, internal rotators, flexors in the elbow, and pronators, and flexors of the wrist. So if you remember the hemiplegic posture, it will be easy. In the lower limb, as you correctly said, it is the extensor. So gluteus will be upper limb, it is flexors, lower limb, it is extensor. Then only you can stand. Are you following it? So gluteus will be hypertonic, quadriceps will be hypertonic, and the plantar flexor also will be hypertonic. Are you following it? Which are in the lower limb?
Glute, quadriceps, and plantar flexors.
One more, you can have adductor muscles also included. Very often adductor spasm can occur in congenital bilateral pyramidal tract lesion. What is that called? Little's disease. One example. Are you following it?
Yes, sir.
So you find bilateral pyramidal lesion from childhood. You find what is bilateral pyramidal lesion, bilateral adduction. What is the gait that will be produced?
Scissoring gait.
Patient goes like this. What is that?
Scissoring gait.
Scissoring gait. That is the explanation for that. So you got glute that are affected. You got quadriceps affected. Plantar extensor, plantar flexion,
Flexors.
plus adductors. So this is the lower limb. Now tell few conditions about hypotonia.
Hypertonia flaccid in element palsy, neuromuscular junction abnormal.
Element palsy, neuromuscular junction may not be altered.
Mm,
So you think of the anterior horn, you got the reflex arc. Tone is maintained by the reflex arc. So if there is a lesion of the peripheral nerve,
yes, sir.
if there is a lesion of the plexus, the reflex arc will be damaged. So you cannot maintain the tone. So LMN, that means it is the anterior horn. I start from the center, anterior horn, then anterior root, plexus, peripheral nerve. Then sensory also is important because impulses have to reach the center spinal cord in order to maintain the tone. So sensory component also is important. Dorsal root is important. So if that is affected, you will find hypotonia. So LMN is one condition. Cerebellum, we already discussed in that. Hypotonia. Any other condition producing hypotonia? Can UMN produce hypotonia?
Yes, sir. In spinal shock.
Spinal shock. Okay. Then one more involuntary movement which will produce hypotonia. Chorea.
Cataplexy.
Chorea.
Yes, sir.
Chorea also is characterized by hypotonia. Are you following it?
Okay.
Then pyramidal tract, I told you about spasticity. I forgot to tell about the extrapyramidal. Extrapyramidal rigidity, opposite of that, you will find not the selective. I told you the adductor, flexors, wrist, pronation, all that. You will find all the muscles, adductors, abductors, flexors, extensors, pronator, supinator. Here, flexion, extension. All the muscles will be, it is a uniform involvement of resistance. Uniform involvement of the in extrapyramidal palsy, you will find all the muscles are affected. Number one. One more finding in pyramidal tract lesion, what is called clasp knife. Clasp knife. Clasp knife will be a feature of pyramidal tract lesion. You stretch like this, there is resistance and suddenly it gives way. Are you following it?
Yes, sir.
Whereas you will not get a clasp knife phenomenon. You will find when you extend it throughout, you will find it is rigid. Are you following it? In addition, you can have sometimes tremor added, which will produce what is called a cogwheel
Rigidity.
Cogwheel rigidity. It goes on in a intermittent fashion. Cogwheel rigidity. And if there is no cogwheel rigidity, it is called lead pipe rigidity. Are you following it?
Yes, sir.
Okay. Now we move on to the next. Continue.
Power.
Motor is normal.
Normal.
Motor power is normal.
Yes, sir. Yes, sir. Power all normal.
Then
reflexes on the knee jerk was pendular, sir. And involuntary.
reflex are normal.
Normal, sir. 2+.
Okay.
And
What about sensor? Sensor they say that? Okay. Through touch, everything has been this one.
yes, sir.
Tell me what are the cortical sensations?
Got 2-point discrimination, stereognosis, graphesthesia, tactile localization.
One more. Tactile localization, tactile discrimination, sensory inattention, graphesthesia, stereognosis. One more, which usually the student does not tell. What about the position sense?
Joint position sensor.
Position sense is a cortical sensation. Posterior column carries vibratory sense as well as position sense. Vibration can be appreciated at the thalamus. Okay. Whereas cortex is required to perceive the position sense. When you are moving up and down, patient is appreciating. Cortex has to function, to be functional in order to, for the patient to identify the, whether it is moving up or down or laterally, whatever it is. So position sense will be a, it is a cortical sensation. Usually students do not mention it. They always think that it's a posterior column. Posterior column carries it.
Okay.
All the sensations will be appreciated at the thalamus. Thalamus is a great sensory relay station. In the thalamus, touch, pain, temperature, crude touch, vibration will be appreciated at the thalamus. If you have got a, suppose you chop off the thalamus here, left side, you will find loss of all modality sensation. Everything, touch, pain, temperature, position, joint, everything will be lost. But cortical lesion above the thalamus, if there is a lesion, that produces a cortical sensor loss. So the vibration comes to the thalamus and the thalamus appreciate that vibration has happened. Whereas it has to ascend to the cortex. If the cortex is normal only, patient will be able to identify the position sense. So it is a position sense, joint sense is a cortical sensation. Along with, you can say that it is a posterior column sensation. Are you following it?
Yes.
So you add position sense also in the cortical sensations. Okay, right.
Moving on to
Now
cerebral.
come to cerebellar science.
She had titubation. There was no
Titubation is there.
no nystagmus. Scanning and
Scanning, staccato.
speech. Hypotonia. Rebound phenomenon was absent. Intentional tremor was present bilaterally. Pendular knee jerk was present. She was not able to perform tandem walking.
1 minute. Go back. Just go back. Why intentional tremor occurs? Already Anand sir has discussed. Still, can you answer that question? Intentional tremor is also called terminal tremor. Terminal tremor.
Okay.
Why is it called? Why is it called terminal tremor? Because suppose I am keeping the object like this, and I am touching. When the my finger is reaching the object, the tremor increases. So precision of movement is maximally required when you reach here. When you are going like this, it need not be precise. When you reach here, it will be exactly, correctly has to be modulated. Then only I can touch normally the fingertip. Are you following it?
Yes, sir.
So when the cerebellum is a place where coordination of agonist, antagonist, synergist, and fixators. What are they? Agonist,
Antagonist,
antagonist,
synergist,
synergist, and fixator. Muscle has to fixate, otherwise it will move. Are you following it?
Yes,
So all the muscles have to be coordinated. And what is the function of cerebellum? Coordination. If the cerebellum is not functioning, there will be incoordination. So one will contract, flexor will, when the flexor is contracting, extensor has to be relaxed equally. Synergist has to also function. So this coordination is lost. Therefore, it becomes jittery. Are you following it?
yes, sir.
So the simply coordination is lost. So instead of smoothly going, trajectory going like this, that cannot happen. It goes on like this. And when it reaches here, it shoots out, shoots beyond. What is that called?
Dysmetria,
No, hypermetria.
hypermetria.
Hypermetria, undershoot, it is called hypometria. Hypermetria plus hypometria is dysmetria. Under dysmetria, both can be described. If it overshoots, it is hypermetria. Again, it's a dysmetria. Undershoot, it is again dysmetria, also hypermetria. So when it undershoots, make a correction. The correction becomes overshoot. So it goes on oscillating.
Yes, sir.
Are you following it?
Yes, sir.
Okay, that is intention tremor. Then What is the commonest tremor you come across?
Essential tremor.
Essential tremor. What are two more tremors you can know about it? You can tell about it. I just describe Parkinson tremor. What are the description of Parkinson tremor? Parkinson also produce tremor.
Resting tremor, sir. Present at rest.
Resting tremor. What is the frequency? It
2
is
to
4
5
to 5. 4 to 5 per second. 4 to 5 hertz. Are you following it? And it occurs when the patient's hand is hanging down. When the patient is trying to raise, it disappears usually.
Yes, sir.
Are you following it? It's a resting tremor. Okay, frequency is 4 to 5. And what is the one more description? What is this? Pill rolling movement.
Pill rolling movements, yes, sir.
Okay. So how do you identify a patient who is walking to you that the patient has got Parkinsonism?
Arm swing will be reduced.
Arm swing will be lost. So what is the, is there any other condition where the arm swing can be lost? One is Parkinsonism, minimal pyramidal tract lesion also, De Jong gives like that. Then cerebellar also he gives. So most important thing you should notice, it is the Parkinsonism. Then 1 minute, excuse me. Sorry, what are they telling?
Parkinson's and cerebellar. Arm swing.
Yeah, arm swing. Arm swing can be lost in Parkinsonism, and then it can be lost in pyramidal lesion, also in cerebellar lesion. That's what De Jong gives. Okay, so that's how you identify. What is our posture?
Stooped posture,
Stoop
leaning
posture.
forward.
Yeah, as if trying to catch the center of gravity. Okay. Then, how do you elicit pendular knee jerk?
While eliciting knee jerk, there will be to and fro. It is not brisk reflex. More than 3 to and fro movement is called as pendular knee jerk.
How do you make the, what is the position of the patient?
He'll be sitting with legs
he
hanging.
Should be sitting. He'll be sitting and to be hanging. More than 3 to 4 movement like a pendulum. It is, what is it due to? Supposed to be due to hypotonia. Are you following it?
Yes, sir.
Now next, pendular knee jerk, tandem walking not possible. Then
coordination test in upper limb. Finger nose test was impaired. A finger nose test is impaired. Drawing circle was not possible. Putting a dot in center of the circle was not possible. Lower limb knee heel test was impaired. There was dysdiadochokinesia was present.
How do you look for the dysdiadochokinesia?
Continuous alternating rapid
alternating movement. RAM, rapid alternating movement. So ask the patient to do like this. That is one way. Another way is ask the patient to tap like this way. Then thumb and each finger, you can do that. And sometimes together. Are you following it?
Yes, sir.
Then alternate supination pronation. When you do that, actually happening is supination pronation is happening. Or you can tap like this. You can tap like this. So the melody will be lost or the rhythm will be lost. It will be irregular. Are you following it?
Yes, sir.
Then how do you look for the alternative movement in lower limb?
Tapping the foot, sir. Foot.
Yeah, tapping the floor. So you can tap like this with the foot, anterior part of the foot. What about the tongue? Where else can you examine? You can examine the tongue. Ask the patient to alternately protrude and go back anterior and posteriorly like this. Then just like a lizard. Then side movement. That rapidly you do it, there will be abnormality.
Yes,
are you following it?
Yes, sir.
Yes. Now
gait, sir. We are not able to assess the gait, but in stance it was wide based and requires 2% support, and there was truncal ataxia while standing, sir.
Okay. Okay. Some of the abnormal gaits, 1 or 2 abnormal gaits. Spastic gait, where do you get it?
In corticospinal tract lesion, there will be spastic gait where the foot has the circumduction gait will be present.
Why there is a circumduction? Why there is circumduction?
Because there is loss of the plantar extensor. Dorsiflexors are lost.
And the reason is we already said that the lower limb it is a flexor hypertonia, upper limb, lower limb extensor hypertonia. So when you walk, you are actually flexing the hip,
Flexing
then flexing the knee and extending, going like this.
yes, sir.
Are you following it?
Yes.
So because the extensors are
Lost.
hypertonic, they cannot flex it. Therefore, in order to take the foot off the ground, when you are walking, the foot has to be elevated, go like this. So in order to take the foot off the ground, patient will rotate it. That is the explanation for circumducting gait. Okay, where you get a stamping gait? Stamping.
In peripheral nerve, sensory ataxia.
Sensory, the classical condition. Example. We already told about it. Tabid dorsalis. Tabid dorsalis. Okay. Then next.
Autonomic nervous system. There was no postural hypertension, no resting tachycardia, no abnormal sweating, no signs of meningeal irritation. Spine and cranium was normal, no bony deformities. Peripheral nerve examination, no thickening of nerves, no trophic ulcer.
Some condition where you get thickening of nerves.
Leprosy.
Leprosy. Hereditary sensorimotor neuropathy.
Hamsan.
Amyloidosis. These are the few conditions. A lot of them are there. Remember them. Neurofibroma also you get thickening of the nerve. Are you following it? What are things you should remember? Leprosy, you said. Then,
then amyloidosis.
Amyloidosis. Okay. Then what is a dissociative sensor loss? In this, what can you describe what is dissociative sensor loss?
Pain and temperature will be lost, whereas the
correct. Pain and temperature is selectively lost. That will be normal. There are few conditions where you get dissociative sensor loss. You can start from the medulla. From there you come down. I will tell you.
Lateral medullary.
There one condition, some syndrome.
Wallenberg syndrome.
Yeah, Wallenberg. What is the sensory dispersion? What is the sensory abnormality? It is described as dissociated crossed hemisensory loss. You can take down. Dissociated crossed hemisensory loss. I'll repeat. Dissociated crossed hemisensory loss. What is meant is you will find either is a left lateral medullary syndrome. You will find loss of pain and temperature on the left side. Okay. On the left side. And on the right side of the body, you get pain and temperature loss. So it's a dissociated crossed hemisensory loss. Just you know of another. There are so many other cross syndromes. Cross syndrome indicates brainstem lesion. Cross syndrome indicate brainstem lesion. Cross syndrome indicate brainstem lesion. Example: Weber syndrome. Ipsilateral third nerve with contralateral pyramid tract lesion. When you go to the pons, ipsilateral LM and facial palsy, contralateral pyramid tract lesion. Are you following it? This is called cross syndrome, cross syndromes. So here also it's a medulla is involved, it's a brainstem. Therefore, that is also cross syndrome. So you describe the sensation as dissociated crossed hemisensory loss. Okay, that's number one. Number two, in the spinal cord. In the spinal cord, few conditions where you get a dissociated sensor loss.
When the spinothalamic tract is affected.
Yeah, conditions. One, syringomyelia. Take down syringomyelia. Syringomyelia, intramedullary tumor. Example: ependymoma. Then central cord syndromes. Even ischemic necrosis of the central part can occur in severe cervical spondylosis. So necrosis of the after trauma or severe vascular lesion involving the central part of the cord. So central cord syndrome. All of them are central cord syndrome. The central cord syndrome encompasses syringomyelia, ependymoma, and necrosis or damage of the inner part of the spinal cord. Okay. Then other condition where you get in the spinal cord itself. What condition? will produce dissociative sensory loss. Anterior spinal artery thrombosis. Anterior spinal artery thrombosis. Anterior spinal artery will supply the anterior two-third of the spinal cord, is it not?
Yes, sir.
Anterior two-third spinal cord that contains the lateral spinothalamic tract that carries the pain and temperature. Therefore, there is a selective loss of pain and temperature. So, anterior spinal artery thrombosis also is a anterior spinal is an example of a dissociative sensory loss. If posterior column is normal, so that therefore there is a dissociation.
Yes.
One more spinal cord syndrome, which I learned in physiology and all that, uncommon, Brown-Sequard syndrome.
Yes.
Ipsilaterally, you get a loss of position joints and perimeter tract lesion, and contralaterally pain and temperature is lost. Brown-Sequard, you can go and read about it. Brown-Sequard, that's also example of dissociated sensory loss. Are you following it?
Yes, sir.
Yeah. Your eyes do not reflect that you are following.
No.
Are you able to hear?
Yes, sir. Yes, sir.
Yeah, no
Audible.
confusion. Okay. Now, come to the nerve. Come to the commonest or most important will be leprosy. Then amyloidosis. That also produces a loss of pain and temperature because amyloidosis is a small fiber neuropathy.
Yes, sir.
Have you heard small fiber neuropathy?
Yes, sir. Yes, sir.
The small fiber neuropathy is there, large fiber neuropathy is there. Small fiber neuropathy will selectively cause loss of pain and temperature. Okay. Whereas large fiber neuropathy will take away the
Touch.
posterior, deep touch, position sense, joint sense. Also, one more feature is areflexia. Areflexia is more characteristic of
Large fiber.
large fiber neuropathy. Whereas small fiber neuropathy usually does not affect the reflexes. So small fiber neuropathy is also characterized by pain and temperature loss. Okay. Then another rare thing is a Tangier disease. Tangier disease. That also will cause selective pain and temperature loss. Then leprosy, between pain and temperature, which is lost first. Temperature is lost first. Then comes the pain. Are you following it?
Yes.
That also can be lost in a severe case, but classical thing is, or start with, there is a loss of temperature, that will be followed by loss of pain. Later only the touch will be affected. So you get another cause for dissociative sensor loss. Okay. Now, carotid pulse is normal.
Yes, sir. No.
What is the carotid hemiplegia? Have you heard carotid hemiplegia? If there is an internal carotid lesion, it will produce contralateral, because this hemisphere is affected. Right side is affected. Right internal carotid is blocked. Mean right hemisphere will be affected. So left-sided
hemiplegia?
pyramidal paralysis, left-sided hemiplegia. Okay.
Yes.
But what is the additional finding that tells you that the patient has got a carotid hemiplegia? Ipsilateral visual loss, because central artery comes from the
Carotid.
carotid artery. Therefore, you will find ipsilateral carotid hemiplegia is characterized by ipsilateral visual loss and contralateral
hemiplegia.
Okay. Then next. Before that, how will you test for neck stiffness?
Next stiffness when patient in relaxed position, first side to side movement, then
Active movement or passive movement?
passive movement.
Before that, what will you make sure? Cervical spine is normal. The casualty, if you do that, sometimes it can cause damage to the spinal cord if there is a trauma. So make sure that there is no trauma. Then you passively flex it. Okay. If patient is put in the supine position or any other position in order to make the neck stiffness manifest.
Supine.
No, that's the classically we are doing. But ideal thing is make the patient sit and patient's lower limbs are stretched. So your patient will be in L shape. You're sitting like this, I am extending my leg, stretching my leg. In that position, you do the flexion. There will be resistance. I have seen so many patients where PG tells that there is no neck stiffness in the supine position. No LP is done. I'd ask the patient, ask the PG student, to repeat it. Patient sitting like L. It is flexed at the hip, knee is extended, and then you do it. Next test will appear. It is a very sensitive, useful test. Very often PGs do it in the supine position. It is not enough. You should do it the other way. So these patients who did not have neck stiffness in the supine position, after asking the PG to repeat it in this way, neck stiffness comes and CSF shows pleocytosis, diagnosis of meningitis was made. So many cases. Are you following it?
Yes.
Yes. Then other systems are on normal.
Normal, yes, sir.
Okay. Now I think it is time. I will request Anand sir. 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 ഞാൻ ഇതെല്ലാം ഒന്ന് കഴിഞ്ഞു. ഇനി സാറൊന്ന് സമ്മറൈസ് ചെയ്ത് തീർക്കാം. സമയം വന്നു. 9
I don't think I have anything to add. It was a textbook of neurology by Sharma sir. Very explicit and a real teacher in all his grace.
Now we have to entertain questions, sir.
Yes.
1 or 2 questions somebody had asked, or you have got any doubt? Something? No.
No, sir.
Illa. Ella അറിയാം അല്ലേ? No, everything.
Before
Okay.
we close, I think I should again thank my younger brother MGK Pillai for giving both of us this opportunity, especially for me to listen to Sharma sir. And MGK Pillai is a real leader.
Yes.
He can make things happen. That's a wonderful quality of MGK. Thank you so much.
Yeah, Pillai, MGK Pillai. Thank you for this opportunity. It's an amazing experience. Sharing with, as I said, the doyen of neurology. And I learned so many points. Just like Sherlock Holmes, he was analyzing. Point by point, from the history itself, diagnosis is reached. That's what great people do. Other people want examination, so they can spot the diagnosis from the very beginning. Story is told, they make a diagnosis. Anyway, that also I have learned. So thank you, Pillai and team, and Anand sir also for being with me. Thanks a lot. Thank you, sir. And you have presented very well.
Thank you, sir.
The points are, everything has been written. Very good. The only thing is you are not bold. Yeah. Pediana.
No, sir. Still more to read.
Okay, okay. Then it's all right. Anyway, all the best for the. When are you writing the exam?
April, sir.
Okay. All the best for the examination.
Thank you, sir.
Okay. Present it like this and win over it. Okay.
Yes, sir.
Right. Thank you, sir. Thank you, Pillai. Thank you, the presenter also. Okay.
Thank you, sir.
Thank you, sir. I would like to thank Anand sir and Sharma sir for the extensive discussions on history and examination. It was actually a phenomenal discussion, and I'm sure not only the postgraduates but also all the faculty also had learned a lot in this session. We are all enlightened actually after this wonderful, phenomenal session actually, sir. So we'd like to thank you very much, sir. If there is any, so there are no questions in the groups. If there's any questions in the chat, we can entertain, sir, but right now no one has entered much, sir.
Hello, Subhash.
Yes, sir.
1 minute. Hello,
Yes, sir.
Subhash. Yeah, I think we were right in selecting the great teachers for the neurology case discussion. Now I am very happy. Okay.
Yes, sir. Yes, sir.
Because I think nothing more can be added by any other person. I was also just like sitting in the neurology class. 2 legends coming together. Rarely only we get such an occasion. So thanks. Especially you have to thank both of them. And also this was a golden opportunity for all of us. Just like you have mentioned. I learned a lot. Thank you very much, sir. Both of you.
Thank you.
Okay.
Thank you. Thank you to all. I think we can close. Thanks a lot.
Yes,
again.
sir. Yes, sir. Yes, sir. Thank you, sir.
Yeah, everybody.
Thank you.
Thank you, sir.
Sure, right.
Yeah.
Thank you.
Thank you, sir.
Thank you, sir.
We'll close the session now, and we hope to meet everyone tomorrow for the next academic session, which will start at 3 p.m. tomorrow. Thank you, everyone. Thank you. Thank you for joining. Thank you.